70 papers for the TR award, and 10, the best of the 70 papers, 10 of the papers have been shortlisted for a TR award. You have all been adjudged for a score of 60 by internal assessors, and now you will be assessed for a score of 40. As this is a free paper, you will have 6 minutes for presentation and 2 minutes for answering the queries. The author and the co-author can answer the queries. The questions can be from the judges and also from the floor. And to note, Professor T. Rajagopal Award is being assessed based on external assessment, the assessment made on this day only.
I request the judges to come to the stage. Dr. Sridevi Narayanan ma'am, Dr. Suresh Chelaya, and Dr. M.S. Vishwanathan. Guidelines என்கிட்ட கொடுத்துருக்கீங்க. அந்த கைட்லைன்ஸ் ஒரு 3 பேப்பர் தான் இருந்தது. இப்பதான் அங்க வேணும்னு வாங்கிட்டு போனாரு. அந்த பேப்பர்ல இல்ல. ஆனஸ் பண்ணிடுறேன். I kindly request the first person to come onto the stage. The first topic for today's discussion. I kindly request the judges, Dr. Sridevi Narayanan ma'am, Dr. Suresh Chelaya sir, and Vishwanathan sir to come onto the stage.
The breakup for your 40 marks will be based on the relevance of the study, the methods employed, statistical analysis, conclusion of validity, time taken for the presentation per se, the slides, and discussion and answer to the questions. Over to the judges.
Madam. I warmly welcome the judges, Dr. Sridevi Narayanan, Dr. Suresh Chelaya sir, and Dr. Vishwanathan sir. And we have the first presenter. The first topic for today's discussion is, can this child with dengue infections be treated as outpatient? You have only 6 minutes for your presentations.
A very pleasant morning to all. This paper seemed relevant in this situation where most of the hospital beds are filled with dengue cases, especially in a city like Chennai, where the parents have to wait for long hours till they get a free bed for their sick child. So with this perspective, we have retrospectively audited the data of our hospital, and this leads us to think, can this child with dengue be treated as outpatient? So when it comes to the goals of management of a child with dengue fever, it's primarily about saving the child from this deadly disease. Now that with early detection of progression of disease and meticulous monitoring and management, the mortality from dengue has decreased to less than 1% in children. And this is the time to address the second goal of reducing the stress financially and monetarily to the parents and the children. So what are the factors that tend to increase the hospitalization rates? This is mainly the anxiety on both the sides, both from the parents and the healthcare providers. Despite of managing many cases of dengue successfully, even one child's death will tilt the balance. So any day hospitalization is a costly affair. And with this perspective, we have thought about a study, and it is entitled, "Can this child with dengue be treated as outpatient?" While reviewing the literature, the study from Lei Yang et al., a 15-year review from Singapore, said that after introduction of a selective admission criteria, the hospital admissions from dengue has reduced from 97.3% in 2003 to 35.9% in 2017 without any concomitant increase in the adverse effects. So aim of the study was to identify children admitted with non-severe dengue who received nil to minimum medical interventions other than clinical and laboratory monitoring, who could have been managed in OPD with regular follow-up. So this study was a retrospective case record analysis conducted in Mehta Multi-Specialty Hospital in 202 children admitted between December 2021 and December 2020 and September 2021. Inclusion criteria was all the children between 1 month to 18 years of age admitted in this tertiary care center with serology confirmed dengue. So demographic details regarding the course of illness, laboratory findings and interventions were collected, and the children who had an uneventful hospital stay were found out. In these children, a pediatric dengue severity scoring was done, and addresses of these children were mapped to identify those who had an easy access to healthcare. All the data were entered in Excel sheet and results presented in percentage and mean plus or minus standard deviation. So this is the distribution of severity among the 202 of the population. 63 of them had dengue fever and dengue fever with less than 2 warning signs. Rest of them, 139, had severe dengue and dengue with more than 2 warning signs. On mapping of the addresses, 25.3% of them were located less than 5 kilometers from the hospital, and 44.4% of them less than 10 kilometers who had easy access to the hospital. Rest 30.1% could have been managed by a referral pediatrician. The mean duration of hospital stay in this group of children were 3.3 days with a standard deviation of 1.2 days. A brief about this pediatric dengue severity scoring 11. This is a scoring system designed in 2020 and validated in last 1 year to decide admission for hospitalization. A score of more than 7 needs definitive hospital admission. It included clinical signs, therapeutic indices, and few lab parameters. Among these 63 children, none of them had a pediatric dengue severity scoring 11 less than or equal to. All of them had a pediatric dengue severity scoring less than or equal to 4. So these were the interventions received by the children with severe dengue and dengue with more than 2 warning signs. Among the 63 children, none of them received any of these interventions. So in this study, nearly 1/3 of the admitted children could have been managed as OP. None of them had any risk factors like obesity or comorbidities like nephrotic syndrome or diabetes mellitus. None of them required PICU admission, and all of them had a PD++ score less than or equal to 4. So who is the right child for OP management? A child with dengue fever with no warning signs or less than 2 warning signs, avoiding risky age groups like infants, avoiding children with comorbidities, children who has an easy access to healthcare, and parents who are willing to bring the child back for regular follow-up and get admitted as soon as the pediatrician suggests. So if they agrees for the same, this can be a sample agreement form where both the parent and doctor should sign after counseling about the course of illness and the interventions the child may require. And this is a simple home monitoring guide wherein an understanding parent can monitor the child easily at home. The child should have a fluid intake of at least 10 times a day, solid intake of 3 times a day, should pass urine at least 5 times a day. Activity can be assessed based on the child is ambulant or bedridden. And if there is any bad signs as suggested here, the child can be asked to bring back for admission. So conclusion, about 31% of the children who was hospitalized could have been treated as as OP in concurrence with the PD++ score less than 4, which is less than 4 for all of them. So the practical application is reducing the cost and stress of hospitalization and making the beds available for the children who are in real need. So how to apply this conclusion in practice? It is the responsibility of both the stakeholders, both the parents and the pediatrician. Parents should be understanding enough to monitor the child at home with simple observation clues and willing to hospitalize as soon as the pediatrician suggests. And pediatrician should have a clear plan for admission with concurrence with the patient. Parents. Thank you. These are my references.
I next request the second speaker to come onto the stage, Messi Mimics. Sorry. I now request the questions from the judges.
Yeah.
Audience also can raise questions if there are any
Very
queries.
nice study. Very useful one actually for this. I just want to ask you one thing. This distance, 5 kilometer, 6 to 10 kilometer, how did you arrive that one? Which is near, which is far?
Sir, we have mapped the addresses and like on an average, the time taken to reach the hospital, where like less than the children who could reach the hospital within less than 1 hour of time in our premises would constitute to less than 10 kilometers.
Did you take into consideration who was the primary caretaker and what was the education or understanding level of the primary caretaker?
Actually, no. Actually, the any understanding, like any regardless of the education of the parent, if the parent is understanding enough, like any mother can say how many times child is taking oral feeds.
No, always the mother does not take care of the child. Sometimes a caretaker, paid caretaker takes care of the child. So did you find out whether it was the parent or the who was the caretaker?
We will have an understanding that we'll explain them. They have to monitor numbers so that they can clearly decide whether the child is at stable range or unstable range. Only for that. Nice study.
Thank you, sir.
We'll move on to the next presentation. The next presentation will be Messi Mimics, Dr. Lakshman and Raj. Lakshan Raj.
Good morning to one and all. Today I'm going to present our study on infections that are mimicking MISI. I'm Dr. Lakshan Raj under the guidance of Dr. Balasubramaniam, Dr. Janani Shankar and Dr. Dhanlakshmi. Multisystem inflammatory syndrome in children have a wide spectrum of presentations. There is no single criteria to diagnose MISI. It's a clinical diagnosis with lab features. We are all well aware of the WHO guidelines that are required for the diagnosis of multisystem inflammatory syndrome. During the initial phase of the pandemic, when we were not well familiar with the diagnosis or terminology of MISI, many of the inflammatory syndromes was misdiagnosed or underdiagnosed as infections. These are the few case reports where it was diagnosed as severe dengue or appendicitis. But now we are overwhelmed, and when we are well aware of this terminology of MISI, we are overdiagnosing MISI because of the seropositive status of the child. As the COVID pandemic tends to be on the rise, the antibody levels also is on the rise and does not guarantee us a diagnosis of MISI. Hence, this study was undertaken to identify the common infections that was mimicking MISI. The aim of this study is to study the clinical presentation and lab parameters of those children with infections that was mimicking MISI. It's a retrospective study ranging from 2020 April to June 2021, It was undertaken in Child Trust Hospital, Chennai after the IEC approval. The inclusion criteria, children between the age of 1 month to 18 years was included, who fulfill the criteria of WHO guidelines for diagnosing MIS-C, where fever along with 2 clinical symptoms, along with antibody positivity for COVID should be present. The results of our study is the total number of admissions during the study period with antibody positive was 205. Though there were 205 children with antibody serology positive, only 135 children fulfilled the criteria according to the WHO guidelines for MIS-C. Even though there were 135 children who had clinical diagnosis of MIS-C, at the end of the day, only 64 children had diagnosis of MIS-C, and remaining 71 children had other alternative diagnosis that was mimicking MIS-C. This is the spectrum in our study, which had the conditions of mimicking MIS-C. The first one was dengue, 30%. The enteric fever, which was culture proven, were counted for 28%. 15% were viral illness, predominantly was COVID pneumonia. 14% was Strep typhus, and the remaining 13% was appendicitis. Among the age distribution, there was no significant difference in the age group between the 2 subgroups of MIS-C as well as the infections that was mimicking MIS-C. Among the gender, there was a slight male predominance in the MIS-C subgroup. These are the rashes that can be seen in some of the infections as well as which can be seen in MIS-C. The first photograph was seen in a child with dengue. The second photograph was seen in a child with Coxsackie illness. And the third photograph was seen in a child with Strep typhus. But all of them presented to us with the clinical features that was very conclusive of MIS-C, but rather had other alternative diagnosis. Among the clinical features between the 2 subgroups on comparing, the rash was significantly higher in the subgroup of MIS-C, that is the inflammatory syndrome. Though rash can be seen in other infection also, nearly 50% of the population in the subgroup of MIS-C had rash. Among organomegaly, hepatosplenomegaly was never seen in the subgroup of MIS-C. So the presence of an organomegaly was highly significant in infection that was mimicking MIS-C. Rash was seen in both the subgroups, but there's a slight predominance of shock in the presence of shock was seen in both the subgroups. There was a slight predominance of shock in the subgroup of MIS-C. Among the echocardiographic findings, the LV dysfunction was found in 14 children, out of which 9 children belonged to the inflammatory group and 5 children belonged to the infection that was mimicking MIS-C, out of which 3 had dengue and 2 had severe viral pneumonia. However, there was no coronary artery involvement in both the subgroups. Among the lab parameters, 3 lab parameters were highly significant in distinguishing the 2 groups. The first of them was CRP, where the cutoff of more than 100, nearly 72% of the children had a CRP of more than 100 in the subgroup of inflammatory syndrome, while 13% of them only had infections mimicking MIS-C at CRP of more than 100. Leukopenia, again, was more in the infection group that was mimicking MIS-C. Only 3% of the children in the MIS-C group had leukopenia. Thrombocytopenia, again, was more in the infection group rather than the inflammatory group. The other parameters like leukocytosis, thrombocytosis, hypoalbuminemia, hyponatremia, though was found to have collaborative evidence in diagnosing MIS-C, did not have any significant difference between the 2 subgroups. The presence of CRP more than 100 milligram per liter and the presence of rash was found to be very statistically significant. Among comparing the 2 groups, MIS-C as well as MIS-C mimics, the mean CRP was 132 in MIS-C as well as 43 in MIS-C mimics, which was found to be statistically significant. Review of literature. This is a case series of bacterial enteritis mimicking MIS-C. The results of a study: if one is suspecting an infection that is mimicking MIS-C, we should have an organomegaly, a CRP of less than 100, and leukopenia. The presence of shock, rash, and LV dysfunction favors more of inflammatory syndrome. Overdiagnosis of MIS-C based on the antibody testing should be avoided, and seropositive status should not be mandated for diagnosis of MIS-C. Presence of rash, shock, and CRP of more than 100 favors MIS-C, while organomegaly and leukopenia favors an alternative diagnosis. Finally, there is a need of universal case definition, as in 2 years into the pandemic, majority of the people are affected with COVID. Therefore, the presence of the antibodies is a non-specific marker or a guideline for diagnosing MIS-C, since majority of them will be antibody positive. Thank you.
Now I invite questions from the judges.
You said some 15% were viral infections. What were they? What viral infections?
Majority of them, ma'am. Out of the 15, the number was nearly 9, ma'am. and 8 of them was diagnosed with COVID pneumonia, ma'am. Only 1 children had severe Coxsackie illness, and the CRP was 38, ma'am. So we had
You mean to say the child had COVID pneumonia with even seropositivity? That is acute COVID as well as background seropositivity.
Yes, ma'am. The seropositivity status was done for the study, and because of the symptoms, we did the RT-PCR also.
How did you diagnose COVID pneumonia in those children? Chest X-ray or CT?
Clinical diagnosis, man. Child had fever, cough, as well as RT-PCR positive, ma'am. We did not do CT for all those 8 children.
RT-PCR can be positive even after the infection.
Sir, the child presented with symptoms of COVID, sir.
No. The child presented with the pneumonia.
Yes, sir. Clinically, the child had pneumonia.
RT-PCR was positive.
Positive, sir. Yes.
But your antibody was also positive.
Antibody.
RT-PCR can be positive even with that viruses.
Sir,
My RT-PCR was positive for 4 weeks.
yes, sir. But clinically also, the child since presented with symptoms of pneumonia, we took it as possible COVID.
Okay, sir, thank you. Next presentation will be prognostic value of shock index in children with sepsis bar septic shock. May I invite Dr. Mumina KM.
A very good morning. A very good morning to one and all. Myself, Dr. Mumina, Pediatric PG from ICHRC Madurai. I take immense pleasure in presenting my topic in Puduvai Pedicon. The agenda of my session will include introduction, aim and objectives, methodology, statistical analysis, discussion and conclusion. Sepsis in children is still a great challenge with the high incidence of mortality and morbidity. The outcome is improved with early recognition and resuscitation of sepsis and septic shock in the first few golden hours of PICU management. The definitions and clinical criteria which I've used in my study comes from 2005 Pediatric Sepsis Consensus Conference. So why did I choose the topic sepsis? Though it's an age-old topic, I did choose it because I was fascinated from the day one of my post-graduation that sepsis is the leading cause of death in both pediatric and adult ICU. So this instilled me to choose this topic. The definitions of sepsis, severe sepsis, and septic shock had been changing over the past few years, but the treatment still remained the same. So familiarizing you with all these definitions. Infection is just a probable or proven case of infection. SARS is just any two criteria of the following four, which I'm going to say. If the individual has got tachycardia, tachypnea, leukocytosis or leukopenia, or hypothermia or hypothermia. Sepsis is cis with any with probable or proven infection. Severe sepsis includes sepsis with one of the organ dysfunction, and septic shock is sepsis with myocardial dysfunction. The shock index that I have used in my study is a simple non-invasive metric tool that can serve as a predictive marker of outcome in children with sepsis or septic shock. It is calculated from just simple heart rate divided by systolic BP. In adults, the normal value of septic shock index ranges from 0.5 to 0.7, and the value more than 0.9 is significantly associated with tissue hypoxia, myocardial dysfunction, and high risk of mortality. This chart depicts a normal cutoff range in pediatric age group. So why did I choose shock index over other scores which are already available? So the shock index which I have chosen is a simple bedside tool. It's a non-invasive tool, and it's inexpensive, and it neither includes any of the laboratory values. The aim of my study is to establish the prognostic value of shock index in the children with sepsis or septic shock. My primary and secondary objectives are to investigate the association between PICU shock index and mortality in children with sepsis or septic shock, to explore the cutoff values for ICU mortality, that is, how the change in shock index over the first 6 hours of ICU admission is associated with the outcome. My study design is prospective study, which has been conducted in PICUs from the single tertiary care center, that is ICHRC Madurai, and 50 children with the diagnosis of septic or sepsis and septic shock are included in the study. The heart rate and systolic BP were monitored at 0, 1, 2, 4, and 6 hours since admission. Finally, the patients were divided into 2 groups according to the death, that is either death or survival. As I've already told, shock index is calculated by as heart rate divided by systolic BP. The mode of measurement of blood pressure was non-invasive. For an unrecordable BP, the systolic BP of 30 mmHg was considered, and during a cardiac arrest, shock index was taken as 0. The trend of shock index during the first 6 hours were noted, and the improvement in shock index was defined as decrease in shock index at 0 and 6 hours. Death was categorized as early or late death. Inclusion criteria included children of age 1 month to 12 years admitted in PICU GRH Madurai, diagnosed as sepsis or septic shock, defined as per International Pediatric Sepsis Consensus. The results of my study are: the mean age of the sample that is included is 4.4 plus or minus 3.4. The sex ratio is equal. Based on the severity, sepsis predominated with 40%, severe sepsis and septic shock with equal of 30%. On the distribution of mortality, between the age group of 1 and 6 years, there's a high mortality of 87.5%. The same has been depicted in this chart. This is the mean shock index values which have been noted at 0, 1, 2, 4, and 6 star, which has been depicted in the same chart. So, by my study, I have finally arrived at a conclusion of cutoff values of shock index at 0 and 6 stars in the respective age values, age groups that I have mentioned already. And the trend of shock index over the course of hospital admission has also been observed. And I've been able to prove that higher shock index values are associated with high risk of mortality. The conclusion of my study is that shock index can be taken as a promising marker of mortality risk in children with sepsis or septic shock. And with the obtained cutoff values, I'm able to identify the risk of mortality, and knowing that the children with elevated shock index may benefit from more aggressive resuscitation and intensive care.
Thank you, Dr. Momina. Over to the judges.
You measured the BP with BP cuff or NABP?
BP cuff, ma'am. Manual BP cuff.
Palpatory method or auscultatory method?
I measured by both the palpatory and auscultatory method.
Did you measure everybody? Or
Sir, I measured, sir.
so many children you were there all the time?
Yes, sir. In our PICU, when the cases have already come, sir, we ask the respective PGs to notify us. So we go there and measure, sir. The 0 hour BP may be measured by one of the other PGs, but the other BPs we measured, sir.
How do you think this study will be applicable?
Sir, the results of my study are highly evidential, sir. I can really prove that the mortality, the group which had high mortality had increasing rate of sepsis index.
Thank you.
Moving on to the next presentation. May I now invite Dr. Meenu Preeti. The presentation will be cardiac manifestations in multisystem inflammatory syndrome in children following SARS-CoV-2 infection. Your time starts now.
Good morning. I'm here to present my study on cardiac manifestation in multisystem inflammatory syndrome in children following SARS-CoV-2 infection. Background of my study: in COVID-19 infection, initially children were thought to have a benign course. Then emerged a new phenomenon called multisystem inflammatory syndrome, which was temporarily associated with SARS-CoV-2 infection. Though MISC has a varied presentation, cardiac manifestation is a crucial among them. Aim and objective is to study the cardiac manifestation with echocardiogram findings in MISC. The methods are: it is a descriptive study done in Department of Pediatrics in PSG IMSR over the study period of 1 year. We have included the children who have been diagnosed as MISC as per the CDC guidelines. We have excluded the children who are a known case of cardiac disease and who are already on cardiotoxic medications like chemotherapy or immunomodulators. All 34 MISC children were diagnosed during the study period are included here. The cardiac manifestation in these children were assessed by echocardiogram performed by the pediatric cardiologist in our institute. We have assessed the echocardiogram findings for the following abnormalities. These data were entered in the Excel sheet and was analyzed using percentage analysis. Results: the mean age was 6.5 years. 79.4% had abnormal echocardiogram findings in our study. This diagram shows the echocardiographic abnormalities, the most common being the pericardial effusion. In 61.7%, we have classified them as trace, mild, moderate, and severe. We had 2 severe pericardial effusion who have even required pericardiocentesis as an emergency procedure. Following this, we had LV dysfunction in 41.1% of the children, which was further divided into mild and moderate. And coronary abnormalities was noted in 35.2% of the children. Mostly it was aneurysm than dilatation, and valvular regurgitation in 31.4% and chamber dilatation in 2.9%. Among the coronary involvement at presentation, LAD was found to be the most common artery to be involved, and isolated LAD involvement was found in 7 children. Isolated LMCA involvement was noted in 3 children, and 2 children had all the 3 artery involvement, that is LAD, LMCA, and RCA. As I already told, aneurysm was most commonly seen than the dilatation, and we had aneurysms as small aneurysms being the most common, and only 1 child had moderate LMCA aneurysm. This is the echocardiogram picture showing the RCA aneurysm with Z-score of 2.7. In moderate LV dysfunction, this is the M mode depicting the moderate LV dysfunction, which ejection fraction of 35%. This picture of pericardial effusion with fluid being collected between the right atrium and the pericardium. The treatment pattern noted in our study, only IVIG was used in 38.2% of the children, and 26.4% of children received only steroids, and another 26.4% received both IVIG and steroids for their better outcome. We had 20.6% of patients with shock. Among them, 85% required inotropes to overcome the shock. This is the length of PICU and hospital stay for all the 34 children. The median length of hospital stay was 5.9 days. This is LV ejection fraction of the children at admission at 2 weeks and 6 weeks. LV ejection fraction more than 55 is considered to be normal. We can see that the line chart have improved at admission and over the 2 weeks and 6 weeks period. This is the Z-score of the coronary arteries at admission at 2 weeks and 6 weeks. The Z-score of more than 2 is considered to be abnormal. We see that at a significant population of children had abnormality at admission, while at 2 weeks, only 1 child had the persistent of abnormality, and at 6 weeks, all the Z-scores were under 2 and it was normalized. All 34 patients in our group were discharged. The median length of hospital stay was 5.9 days. Of the abnormal echocardiogram group, we had follow-up data for 20 patients. All these patients were clinically stable during follow-up without any long-term complication, and their abnormal echocardiogram findings were resolved. Discussion: we have compared our study results with the similar studies who had inclusion criteria same to us and who had a short-term follow-up also. Among this population, cardiac abnormalities was noted in 66% in Christian et al. And in our study, it was 79%. LV dysfunction was found to be the common presentation, with accounting for 53% in Severity et al. Whereas in Christian et al. It was 52%, and in us it was 41%. Coronary aneurysms were noted in 33% in Severity et al. And in Christian et al. It was 52%, and in our study it was 35.2%. All these abnormalities in all the studies have been found to have resolved over the follow-up period of 2 to 6 weeks. Strength, the selection criteria we used was as per CDC guidelines, and we did not have cardiac dysfunction as a mandatory criteria. And this echocardiogram was found performed by a single cardiologist to avoid the observer bias. Limitation, it is a single center study with medium sample size. We have lost follow-up in few patients, so these data are lacking. Future implication, these data may help to identify the post-vaccination myocarditis. As we see, there is a good outcome during the follow-up period. We should have high index of suspicion with multidisciplinary team to diagnose MISC and start appropriate treatment at earliest. Long-term follow-up should be studied in future. Conclusion, cardiac involvement is the most common manifestation in MISC. With appropriate early management, they will have excellent short-term outcome. Thank you.
Thank you.
Out of the
Out of
7
this?
patients whom you could not get for follow-up, did you have their phone numbers? Did you make attempts to call them?
Yes, ma'am. We contacted them. They told that they had no further problems, so they did not
All
come
7
to us.
were alive.
Alive, yes, ma'am. Alive, ma'am. They have visited the nearby pediatrician, and we have prescribed aspirin for all these patients, ma'am. They have also titrated and stopped that with consulting with the nearby pediatrician, ma'am, in their locality. But they didn't come to us. We contacted them to telephone.
In your data, 87% of patients required ionotropes. Is it
Yes,
so
ma'am.
much? 87% required ionotropes.
No, ma'am. 85% of the shock patients, ma'am. We had a shock percentage of 20% only. That is among 15 children. In them, 85% required inotropes.
Thank you. Good study again. And I just want the duration of the inotropes.
Duration of inotropes, ma'am. Sir, it was the mean duration. We have we have the data, sir. It was 10 hours. Median duration was 10 hours.
Valvular regurgitation. Which valves they're involved mainly? The valvular.
Valvular regurgitation, we noted our mitral regurgitation and tricuspid regurgitation.
And I know your follow-up period was 2 to 6 weeks time.
2 to 6
My
weeks.
suggestion is just to know what's happening, 6 months or 1 year later also, whether they stay normal.
Yes, sir. We had only for 4 to 5 patients with follow-up data at 6 months, sir, but not for all the children. So we didn't study that. Sir? Yes, sir, they're fine. Even at 6 months, their echo are normal only.
Thank you. Nice study.
Thank you.
Next speaker on the stage, Dr. Manon Charitra, a study on Prasozin therapy for scorpion inflammation at primary healthcare level after training and the complications and outcome at tertiary care center.
Good morning to one and all present here. I am Dr. Manoj Chitra from Government Dharmaburi Medical College Hospital. I thank honorable judges and organizing committee for giving me this wonderful opportunity. My study is on Prasozin therapy for scorpion envenomation at primary healthcare level after training and their complication and outcome at tertiary care center. Scorpion envenomation is an acute life-threatening pediatric medical emergency. More than 99 species are identified, in that Mesobuthus stamulus and Palmanius vermeerdermi are very poisonous. If not treated properly, death can occur up to 25% of children below the age of 5 years. Cardiac manifestations are most commonly seen in Indian red scorpion, in that pulmonary edema is the most common complication due to cardiac toxicity. Prasozin is the gold standard therapy for scorpion envenomation. Prasozin, it is an alpha-1 blocker. The mortality and morbidity of the scorpion envenomation is directly related to the sting Prasozin interval. In the past, various regimens are arrived, but after the arrival of Prasozin, the mortality is significantly reduced. In our previous study, which was conducted at January 2013 to December 2016 from 260 children, the Prasozin given to scorpion envenomation at primary healthcare level before referral is only 3% because of lack of knowledge on clinical features and management of scorpion envenomation at primary healthcare level. So many children developed a significant complication and needed ICU care. So, improvement of the knowledge of PHC doctors on scorpion envenomation as well as other pediatric emergencies is very much mandatory to prevent late complications of pediatric illnesses. So, we plan to give training for the medical officers in our district. The training was conducted at January 2018 to December 2019 from 51 PHCs, including urban PHC, and from 4 GH, including 130 medical officers. After the training period, we plan to conduct a study to know the impact of our training on scorpion envenomation. My objective were to evaluate the initial prazosin therapies for scorpion envenomation at primary healthcare level after training given to the medical officer, and to evaluate their complication and outcome at tertiary care center after referral. My study is prospective observational study, which was conducted in Department of Pediatrics, Government Dharmaburi Medical College Hospital from January 2021 to September 2021. All children aged 1 month to 12 years of age with features are history suggestive of scorpion envenomation are included in the study, and children admitted with unknown bites with features not suggestive of scorpion envenomation are excluded from the study. And we conducted a study to evaluate the impact of our training and the improvement in outcome of scorpion envenomation at our center. After the admission, the basic details noted and time of sting, site of sting, referred from which PHC or GH, and treatment details given at the PHC and GH are noted. Clinical features and complications are noted, and management outcome also noted. Previous study and this present study were result tabulated and analyzed using Mann-Whitney U-test. Coming to the results, 81% of children are referred from primary healthcare center, and in total, 69% of children received prazosin before coming here. 1 to 6 years is the most common age group is observed in my study. Most common symptom is pain followed by diaphoresis, salivation, and vomiting. And coming to the signs, most common sign is cold peripheries, which accounts for 48%, followed by tachycardia and shock. Around 72.5% children received prazosin within 4 hours of sting. Coming to the complications, shock and pulmonary edema is the most common complication noted in my study, for which inotropic support like dobutamine needed in 22% of cases and non-invasive ventilation needed in 19% of cases. No one needed invasive ventilation. On comparing previous study with present study, prazosin administration was improved from 3% to 69%, which is statistically significant. And shock also reduced from 76% to 39%, which is also significant, statistically significant. And pulmonary edema is also significantly reduced. And inotropic support and non-invasive ventilation also significantly reduced. No mortality in my study. Coming to the discussion, scorpion envenomation is an important public health hazard in tropical and subtropical regions. Pulmonary edema occur mostly within 30 minutes to 3 hours after the sting, which is a common cause of death. In children, many times scorpion envenomation present as unknown bite because it hides in self, shoes, and bags. Though the same amount of venom is injected in both children and adults, due to lesser body surface area, envenomation is significant. In studies like Ganesh et al. And Kumar Prasad et al., lesser the sting prazosin interval, lesser the complication. Same ways in my study, prazosin administration within 4 hours is improved, so complications are reduced. Other studies like Mahadevan et al. And Bavaskar et al., which was conducted using a scorpion antivenom with prazosin, which in both studies, it's accelerated detection recovery time. But prazosin is a very much cheaper, which was so stated in Bavaskar et al. Study, but scorpion antivenom is not widely available in India. When primary healthcare medical officers started using the prazosin, which is easily available and cheaper one, is indicated cases earlier in our study. Complication reduced and duration of treatment also reduced. India is a country where villages and rural areas are more. So any type of illnesses, public first go to nearby healthcare facilities like PHCs. And any serious diseases like dengue, scrub, initial management in PHC is very important to reduce morbidity. So our studies shows light on this under treatment and bridges the gap between PHC and tertiary care level for the treatment of scorpion envenomation. Strength of my studies, this is a pilot study. Both studies were done on relatively large volume of children in same institute. Limitation is some of the untrained doctors are posted in the PHC after our training period. This may influence our study results. Coming to the conclusion, after the training program, prazosin therapy for scorpion envenomation at PHC were increased from 3% to 69%. Likewise, complications also reduced and need of ICU care also reduced with good outcome. So my recommendations are periodical training of primary healthcare medical officers and primary practitioners about all pediatric emergencies, including tropical fevers, envenomation or emergencies are very much important. And this initiation will decrease the complication and improve outcome in children and decreases the under 5 mortality. Thank you.
Actually, I was there in that poster presentation when you presented your last study. It wasn't you, it was somebody else, I think. And did you get that published? Was that study published? That was a recommendation at that time to publish that study somewhere.
Before the poster presentation, the old study was published, sir. At the time at the time of 2018, the training was going on, sir.
I have another comment. Even though children are from rural areas, mothers are from rural areas, they have a right to privacy. All your photographs had no bright faces, and that should be avoided in future in any public presentation.
Two things. Nice study because you had an initial study and you followed up. That's very good actually. And but the thing is, I want to know is for the prozosine. What is the average or mean duration within which you have administered in the study? Within how many hours? The mean. So probably I think as Dr. Suresh Chale has mentioned that you should go over for the publication of this one, and then probably you should what to say, take these results to the other districts also.
Thank you, sir.
Center, Dr. Monisha. Topic is thrombocytosis as a predictor of serious bacterial infection in young infants.
Good morning to all. And my study topic is, I thank my professors and the Pedicon team for giving me this wonderful opportunity. My study topic is thrombocytosis as a predictor of serious bacterial infections in young infants. As a febrile infants with the localizing signs are a challenge to clinically distinguish between serious bacterial infections and self-limited viral infections. The prevalence of bacterial infections in infants of less than 3 months old is found to be 20 to 25%. What are serious bacterial infections? They are invasive infections such as bacteremia, urinary tract infections, pneumonia, bacterial meningitis, infections of skin and soft tissue, and bacterial gastroenteritis. Some of the easily available laboratory markers to predict serious bacterial infections are RICE WBC, ESR, CRP, and procalcitonin, and of course thrombocytosis. Why I have chosen this topic? Because many of the widely available automated hematology analysis can easily predict the platelet count. Although WBC is easily available for predicting serious bacterial infection, the sensitivity was found to be very low than predicting as thrombocytosis. Infections. In case of infections, these lead to the release of cytokines, interleukin 6, and this in turn activates a hepatic thrombopoietin, which lead to megakaryopoiesis. So in case of any serious bacterial infections, thrombocytosis can be taken as a predictor for further management. And the review of literature. I reviewed several literatures, and I found that in the study conducted by Deepak Mishra et al., he found that the thrombocytosis alone has a sensitivity of 53.5%, and the specificity was found to be 90.9%. And while he combined all the laboratory parameters, he had better sensitivity than individual parameters alone. And the study conducted by Shumila Manzoor et al., he found that the mean platelet count was 1.5 lakhs in serious bacterial infections versus 3.9 lakhs in non-serious bacterial infections. And he found that his study was statistically significant. And my aim of the study was to detect the incidence of reactive thrombocytosis in febrile young infants. And the objective was to assess the utility of platelet count as a predictor in serious bacterial infections. And the methodology, I conducted my study in ICHRC, and the study design was hospital-based prospective observation study, and I recruited about 140 young febrile infants. The inclusion criteria was the infants of less than 1 to 3 months of age, those who are admitted with fever. And I have excluded some of the infants who have previously treated with antibiotic prior to the presentation in a hospital, and those who had a history of recent vaccination, infants with anemia, and those who are already on iron supplements and corticosteroid therapy. I have collected various data and I sent for sepsis evaluation. After that, I have categorized them into serious bacterial infection group and non-serious bacterial infection group. And the statistics were, in my study, the spectrum of diseases were 69% of them was from the non-serious bacterial infection group, and in serious bacterial infection group, 19.20% was from pneumonia, or among pneumonia. The mean platelet count in serious bacterial infection and non-serious bacterial infection was, the pneumonia has the highest mean platelet count, that is 5.8 lakhs. And in non-serious bacterial infection in my study, the platelet count was 3.7 lakhs. The platelet count in serious bacterial infection versus non-serious bacterial infection, I found that the percentage of thrombocytosis in serious bacterial infection was 65.9%, and in non-serious bacterial infection, it was just 75%. The platelet count, which is when it is more than 4.5 lakhs, the sensitivity was found to be 65.9%. And when it is more than 8 lakhs, the sensitivity was very low, 17.25%. So I have chosen the cutoff of 4.5 lakhs for detecting the maximum number of serious bacterial infections. Comparison with other parameters. I have compared with other parameters such as CRP, WBC count, and with the urine microscopy with pyuria. The sensitivity was found to be in thrombocytosis. In my study, the sensitivity was 65.9%, and when combining with the thrombocytosis, WBC count, CRP, and pyuria, the sensitivity was higher. It is 100%. Coming to discussion, out of 140 infants I have studied, the sensitivity was WBC count versus thrombocytosis. The sensitivity was WBC was just 45%, and thrombocytosis was 65%, and the specificity was 29%, and the specificity of thrombocytosis was 62%. When comparing with other studies with Mishra et al., the incidence of serious bacterial infection found in Mishra et al. Is 56%, and in my study, the incidence was just 33%. But the sensitivity of thrombocytosis in Mishra et al. Was 53%, and in my study, the sensitivity was 65%. In comparing the study with Mirin et al., the mean platelet count in serious bacterial infection study conducted by Mirin et al. Was 44.8%, and in my study, it was 5.4 lakhs. Coming to conclusion, the estimation of platelet count in infants with fever can predict serious bacterial infection, and it is also a cost-effective investigation. When comparing with the sensitivity with WBC sensitivity was found to be very low, and sensitivity of reactive thrombocytosis is 65%. So we can easily take the thrombocytosis as a predictor of serious bacterial infection in treating infants. Thank you.
Thank you, and a very good study again. I just want to ask you, the specificity of 62.5, do you think that's enough? The specificity of 62.5, is it a good number, you think?
So specificity is not that much good in my study, sir. But so when it is more than 80% means we can take it as a good number. But in my study, it was only 62%, sir.
The other thing I want to ask you is this, the serial values. Do you done any serial values of platelets?
Yes, sir.
Is it one-off value? Has it done any serial values done on the next 2 days, 3 days?
Yes, sir.
Does it tells us anything more?
So I have not studied the serial values of platelet. I have just taken that presentation count only, sir. While the infants are presented to a hospital, what was the platelet count only I have studied, sir. I didn't study the serial first day, second day of hospitalization. I didn't study that, sir.
And apart from fever, is there any other symptoms?
Yes,
Did you find any difference of any predominant symptoms being associated, particularly with this high thrombocytosis?
Yes, sir. Those infants with anemia has thrombocytosis, sir, and those were already on corticosteroid therapy and iron supplements also. They had thrombocytosis, sir. So I have excluded them from my study, sir.
I'm saying any symptoms, any particular symptoms apart from fever?
Apart from fever, any symptom? It's a paler due to anemia.
Did you try to do a ROC curve and try to find out the cutoff above which there is more probability of sepsis?
So, ma'am, I have done only chi-square test, ma'am. I didn't do ROC curves, ma'am.
What blood did you use for doing the sampling? Heparinized or EDTA? Because,
sir, I didn't get it.
What are the sample sent for your platelet count or a CBC? Heparinized?
Sir, I have sent that EDTA sample only, sir.
That itself can cause a little bit of
yes, sir,
observed variation, bias, sampling error in.
Yes, sir. That are limitations of the study.
Thank you.
Thank you, sir.
Thank you. We'll move on to the next presentation. I invite Dr. Jnana Sundaram. He'll be presenting on clinical predictors of prolonged hospital stay in bronchiolitis. So, Divya, utility of rapid diagnostic tests for diagnosis of malaria infection in children. Dr. Divya.
Good morning. I'm Dr. Divya. I'm doing MD Pediatrics at Stanley Medical College. I'm here to present a study on utility of rapid diagnostic tests for the diagnosis of malaria in children. I have done the study under the guidance of Professor Dr. Ganesh sir and Dr. Manish Kumar sir. Introduction.
Don't relax. You will not take this time. Don't worry.
Introduction. Malaria is one of the primary causes of pediatric deaths.
Change the time.
I'm here to present a study on utility of rapid diagnostic tests for the diagnosis of malaria in children. Introduction. Malaria is one of the primary causes of pediatric deaths. Children under 5 years are the most vulnerable group and they account for 2/3 of malaria deaths worldwide. So the main strategy for malaria control is rapid and accurate diagnosis. Need for the study. We all know microscopy remains the gold standard test for the diagnosis of malaria for more than a century. It has good sensitivity and it identifies various species and its stages and the level of parasitemia. Despite these trends, microscopy is time-consuming, labor-intensive, and requires a high level of technical expertise. So an easily performed test that is more sensitive and equally specific would be desirable to augment the malaria diagnosis, especially in resource-limited settings. The rapid diagnostic test is an effective alternative for microscopy as it is simple, easy, and accurate and does not require any extensive training. Objective. My primary objective is to compare the rapid diagnostic test with the microscopy for the diagnosis of malaria in children. And my secondary objective is to compare the results with the clinical outcome. We conducted this cross-sectional study over a period of 6 months in Institute of Social Pediatrics, Government Stanley Medical College. Inclusion criteria, children less than 12 years of age with features suggestive of clinical malaria were included in the study. That is, fever less than 2 weeks with hepatosplenomegaly or isolated splenomegaly with or without clinical pallor. And those who had taken anti-malarial therapy within 2 weeks of presentation were excluded from my study. And those subjects we included were subjected to both microscopy and rapid diagnostic tests. Thick and thin blood smears were made within 10 minutes of sample collection, and the smears were examined by a trained technician using standard methods, which was confirmed by a pathologist. Now, all smears were examined by a same person to eliminate the intra-observed variation. And RDT was performed by 5 microliter of blood. This kit contains monoclonal antibodies specific to histidine-rich protein 2 of Plasmodium falciparum and lactate dehydrogenase of Plasmodium vivax, and the results were read within 20 minutes. And following microscopy and RDT, subjects tested positive for malaria either by microscopy or RDT were treated with antimalarials according to the protocol after ruling out other tropical infections. And the subjects were followed up daily for effervescence. Clinical response was defined as fever clearance for at least 4 consecutive days after treatment. And the collected data was analyzed using SPSS software. To find the significance in categorical data, chi-square test was used, and to find the efficacy, receiver operator characteristic curve was used. In my study period, totally 952 subjects with fever were assessed. Among them, 88 satisfied the inclusion criteria, and 17 were excluded due to antimalarial therapy within 2 weeks of presentation. And total of 71 subjects were enrolled in my final study. Among the 71 subjects, both microscopy and RDT positive malaria in 28%, whereas only RDT positive in 38%. That is, among the 71 subjects, RDT positive subjects were 66% and microscopy positivity was only 28%. This 28% positive results in microscopy were concordant with the rapid diagnostic test, and the species identified by microscopy were same as rapid diagnostic test. And it was statistically significant. And this slide shows the species identified by microscopy and rapid diagnostic tests. In both the tests, the predominant species being Plasmodium vivax followed by Plasmodium falciparum. Even though microscopy showed negative results, those who have RDT positive were treated with antimalarials after ruling out other tropical infection. All of them had a significant clinical response and it was statistically significant. And to find the efficacy of RDT, we compared RDT with the microscopy, considering microscopy as a gold standard. And the sensitivity of RDT is 100%, specificity is 48%, positive predictive value is 44%, and negative predictive value is 100%, and the accuracy of test is 63.4%. And the clinical response rate in microscopy negative, but RDT positive subjects are 100%. If this was, the clinical response was taken as a criteria for comparing microscopy and RDT showing better results compared to microscopy. The area under receiver operator characteristic curve of RDT for diagnosing malaria was 0.740 with a p-value of 0.001, which was highly statistically significant. A discussion, in my study, totally 66% of subjects tested positive for malaria by RDT, whereas only 28% subjects were tested positive by microscopy. There were 100% clinical response rate in microscopy negative but RDT positive subjects. On comparing the results of microscopy and RDT with the clinical outcome, there were 38% false negatives in microscopy. This signifies that RDT yielded a better results compared to microscopy. Literature review, there are several studies in the literature showing the superior diagnostic performance of RDT over microscopy. Study done by Bezos et al. Showed RDT had a better sensitivity and specificity compared to microscopy using PCR as a reference standard. Limitation, in our study, we evaluated RDT using microscopy as a gold standard, fully aware of its limitation. So specificity, positive predictive value, and accuracy were low in our study. So the comparison of RDT with another specific test like qPCR or PCR could have improved the specificity, positive predictive value, and accuracy in the study. Further studies are needed to confirm this. And to conclude, even though specificity is low in my study, because of the 100% clinical response, we conclude that RDT is more suitable for diagnosis of malaria in resource-limited and expertise-limited settings. These are my references. And I'd like to thank my guide and the organizer for giving me this opportunity.
Who did the RDT? Yourself or technician?
RDT was performed by me, ma'am.
Okay. And smears were seen by technician or pathologist?
Technician, trained technician, which was confirmed by a pathologist, ma'am.
All smears were confirmed by pathologist?
Yes, ma'am.
Okay. Is RDT approved by WHO?
Yes, ma'am.
It is approved as one of the tests.
One of the tests, either microscopy or RDT should be done before starting antimalarials.
Okay. So what is new your study adds? It is already approved by WHO. So what is the new thing you're trying to say?
Ma'am, in our study, even though microscopy showed negative results, RDT positive patients are showing 100% clinical response, ma'am. Like we used two antigens, both HRP2 and lactate dehydrogenase antigen. This test showing better results compared to some other studies, ma'am.
This RDT was procured by government or you procured it?
I procured, ma'am.
Good study. So in future, are you going to say that RDT will replace?
So no, sir. Yes. Microscopy is always the gold standard, sir. But in resource-limited settings and peripheries where a microscopy is not available, we can use RDT as a diagnostic tool before starting antimalarials.
Thank you.
Thank you, sir. Thank you.
I invite the next speaker on the stage, clinical predictors of prolonged hospital stay in bronchiolitis, Dr. Jnana Sundaram.
Very good morning to all. Thanks for this wonderful opportunity for Predictor. Yes, I am Dr. Jnana Sundaram, PG in this Stanley Medical College. I am going to present my study, the clinical predictors of prolonged hospital stay in bronchiolitis. Bronchiolitis is an acute infectious inflammatory disease of lower respiratory tract resulting in obstruction of small airways. Most common serious acute respiratory illness in infants and young children. Clinical spectrum ranges from mild illness to severe course manifested by apnea, ICU care, intubation, and even death. Bronchiolitis also represents a major healthcare and financial burden in all developing countries. There is a significant association between length of hospital stay and certain demographic and clinical predictors easily obtainable in a E-room and first day of admission. Pre-bronchiolitis admissions and severity prediction models have focused more on birth and disease-related risk factors than an hospital course factors, and particularly common clinical assessment and including respiratory status. Having a reliable risk factors to identify infants at a high risk for prolonged length of stay early in the course of an admission would be helpful, both for clinical care and for the studies of interventions designed to reduce the length of the stay. The aim of the study is to identify the clinical predictors on a day one of hospitalization, determining the length of the stay in hospitals. This is a cohort study. It's done in Institute of Social Pediatrics, Government Stanley Medical College. It's done by this consecutive sampling method. As I get 220 cases, and the study duration was 14 months from September 2022 to October 2021. We included the previously normal children aged 1 to 24 months. First episodes of these suggestive of bronchiolitis. We exclude the cases of infant aged less than 1 month and more than 24 months. Previous episodes of wheezing, children with underlying respiratory disease like a chronic lung disease, recurrent pneumonia, cardiac diseases like a congenital heart disease and myocarditis, immunodeficiencies, congenital and acquired, and signs of sepsis. We use the discharge criteria, SOFA criteria used for the discharge. It contains a not dependent on suctioning, off oxygen, family agreeable to discharge, follow-up plan in place, feeding well enough to maintain hydration, not requiring acetylene or saline nebulizer, respiratory status acceptable. Infant and children diagnosed as bronchiolitis segregated into 2 groups. Short length of the stay, which is staying less than 96 hours, and prolonged length of stay, which is stays more than 96 hours. Data of history, examination findings, and risk factors, laboratory parameters recorded like history in presenting complaints, birth details, and clinical assessment, and laboratory parameters. And statistical analysis done by SPSS software version 24.0. The factors predicting hospital stay are analyzed. We have the results of a total of 220 children were analyzed in our study. Mean age was 6.4 months with a standard deviation of 4.6 months. 130 children, nearly 59% with 1 to 6 months, and 30% with 7 to 12 months. Regarding to history, the age less than 6 months, male gender, more than 2 days of respiratory distress, and more than 3 days of the illness at the time of the admission came with the significant p-values. Regarding to the presenting illness, the high-grade fever with temperature more than 102 degrees Fahrenheit, grunting, dehydration, refusal of feed, came with just significant p-value. Regarding to birth-related history, the birth weight less than 2.5, just preterm babies, and the need of the respiratory support at birth and failure to thrive, which came with a significant p-value. Regarding to the clinical assessment, heart rate more than 160 per minute, respiratory rate more than 60 per minute, the admission time, just saturation, SpO2 is less than 94%, nasal flare, chest retraction just came with a significant p-value. Laboratory parameters, the chest X-ray, abnormal chest X-rays, hemoglobin less than 10, and sodium level less than 135, and CRP positive, just gave the significant p-value. Discussion. In our study, we find strong association between a number of clinical assessment and length of the stay in hospital. Parameters such as higher maximum respiratory rate, prematurity were statistically associated with prolonged hospital stay inconsistent with study done by Michael et al. And Gabriel et al. In Michael et al. Study, length and amount of the oxygen received, minimum oxygen saturation, maximum respiratory rate, calorie intake, gestational age factors predicting the prolonged length of the stay. In Gabriel et al., the age less than 2 months, poor feeding, oxygen saturation less than 90, apnea, nasal flaring, grunting, and the dehydration and retraction are associated with the postulated predators and escalated care. In our study, we have limitation of it's a retrospective study of a single bronchiolitis station at a single institution. 4 out of 5 markers in our model are clinical markers that could vary based on clinical assessment skills and institutional practice. Environmental and social risk factors such as daycare attendance, school-age siblings, and smoke exposure can impact the length of the stay, but were not included in our model. To conclude, this about discuss factors. These clinical markers identified on day 1 of the hospitalization determine the prolonged stay of hospitalization. This study could be applied for yearly identification of high-risk children and start intense treatment, and for a yearly recovery and also to reduce the morbidity and malaria bronchiolitis. Thank you.
Thank you, sir. Questions to the judges?
These are all general danger signs.
Yes.
You've not picked up any specific thing which will predict the course.
Ma'am?
No, whatever you have mentioned are general danger signs.
Yes.
No?
This is the what we can see in E room, ma'am. Just when we sit with the child in E room, this is the finding we are going to see. Just if busy E room, just easily maybe left out some finding, and child is treated as a OP patient or discharged, or maybe admitted and start a simple treatment.
What was the mortality rate in your study?
Actually, mortality is nil only, ma'am. There's a pancreatitis cases admitted as a pancreatitis, and further
All
investigation.
220 patients survived.
Just after confirming the investigation, the studies become sepsis or bronchopneumonia changes diagnosis bronchopneumonia, ma'am.
You mentioned
diagnosis
about
confirmed.
X-ray changes. What were the X-ray changes you saw?
Mainly hyperinflation, ma'am, and mild infiltration, paracardic infiltration, ma'am.
Okay. And out of the length of the stay, what was the minimum length of the stay? What was the maximum length of stay?
Maximum length of the more than 11.5 days, ma'am. Minimum length of stay 3 days, ma'am.
Which even said
Yeah.
salbutamol nebulization for bronchiolitis. I mean, that is not an accepted form of treatment at all.
Yeah, that's but the church for that, the Sophocles is followed in many studies, sir. And in Sophocles, they put a albuterol or acetylene nebulization is they mentioned in this. No further nebulization or just more than 6 hours of nebulization free is considered as in such criteria.
Thank you.
Thanks.
Thank you, sir. We'll now invite Dr. Bala Vigneshwari, a study on clinical profile and outcome of multisystem inflammatory syndrome in a tertiary care center.
Respected judges and organizing committee, I thank each one of you for having given me this wonderful opportunity. My study is on the clinical profile and outcome of multisystem inflammatory syndrome in children in a tertiary care center. Introduction, it is multisystem inflammatory syndrome. It's a recent pandemic having epidemiological linkage with SARS-CoV-2 infection. It is characterized by unremitting fever of more than 38 degrees Celsius for more than or equal to 3 days. Just as COVID is new, MIS-C is all new to us. It's another piece of an expanding puzzle. Risk of underdiagnosis and undertreatment here is inevitable, as many children were asymptomatic during the first and second wave of COVID. Also, these cases resemble some common tropical infections and sepsis. In India, MIS-C cases were reported since late April 2020. Objectives are to study the clinical profile, complications, and outcome of children with MIS-C admitted in a tertiary care center. Our study is a prospective observational study conducted at Department of Pediatrics from May 2021 to October 2021. Children presenting with fever for more than or equal to 3 days from 1 month to 12 years of age, having elevated markers of inflammation with recent evidence of COVID-19 infection, having no other obvious microbial cause of inflammation are included in our study. Children presenting with clinical and laboratory features suggestive of some tropical fevers, toxic shock syndrome, bacterial sepsis, and all other pediatric diseases with incidental COVID antibody positive were excluded from our study. Children presenting with acute febrile illness, fulfilling the diagnostic criteria of MIS-C, were included in our study. All the demographic details, clinical features, and laboratory investigations of children was collected. Signs and symptoms, complications, treatment, and outcome are tabulated. Ethical committee clearance and informed consent are obtained. Results showed age distribution maximum between 3 to 6 years of age. Gender distribution showed male preponderance. In our study, about 22% of cases had contact with COVID positive family members in the past. Apart from fever, almost many children presented with GI symptoms like abdomen pain and vomiting as the major presenting complaint. Conjunctivitis was present in 54% of children, and skin rashes was present in 15% of children, and only 11% of children presented with bleeding manifestations and coagulopathy. Laboratory parameters showed almost 100% of children was tested COVID antibody positive in our study. Almost about 82% of children had elevated CRP, and 68% of children had thrombocytopenia. About 71% of children presented with shock, among which 84% of children required inotrope support. This was a maximum of 4 inotropes was utilized in 15% of cases, and 1 inotrope was used in 55% of cases. About 22% of children presented with distress, among which 20% required O2 support under nasal prongs, 40% required HFNC support, and 20% required NAV support, and 20% of cases required mechanical ventilator. In our study, about 94% of children recovered with IV methylprednisolone alone, and only 6% of children were administered IV immunoglobulin. Almost 98% of children recovered. As far as MIS-C is concerned, in this post-COVID era, high index of suspicion is needed, as no child presented with MIS-C was tested COVID positive in the past in our study. Parents and general physicians might not be aware of this recent condition, which may lead on to late clinical attention. When there is a delay in initiating treatment, these children may end up with multi-organ dysfunction. Similar to the study by K. Dhanlakshmi et al., our study also had little lesser age group of presentation between 3 to 6 years. Male preponderance was seen. MIS-C has got varied clinical presentation ranging from GA symptoms, mucocutaneous changes to bleeding manifestations. But in our study, GA symptoms were predominant. About 68% of children had abdomen pain and vomiting. Although there are studies citing the importance of mucocutaneous changes as a major presenting complaints, only 53% of children presented with conjunctivitis in our study. About 40% of children had cardiac manifestations, among which mild LV dysfunction was present in 15 cases and severe LV dysfunction was present in 3 cases. In our study, there was no echocardiographic evidence of coronary artery changes seen. Although the incidence of coronary artery changes ranges from 17% to 93% in several other studies. Laboratory investigations showed elevated CRP among 82% of cases. And in our study, 2 cases were tested IgM, dengue and COVID antibody positivity with persisting fever, along with shock requiring multiple inotrope support with elevated markers of inflammation and coagulopathy requiring blood transfusions. 1 case improved with IV steroids and IV immunoglobulin. Co-infection with MIS-C poses a serious challenge and it needs a timely intervention. Although there are studies citing the importance of administering IV immunoglobulin alone or IV immunoglobulin along with steroids, in our study, about 94% children recovered with IV methylprednisolone alone. Only 6% of children required IV immunoglobulin. Treatment with IV immunoglobulin in a resource-limited setting like us is a real-time challenge, and high cost and availability is of serious concern. Use of methylprednisolone as first-line treatment for MIS-C was associated with favorable immediate and short-term follow-up outcomes in our study. Limitation of our study are small sample size and observational nature. In a setting where a child presents with persisting fever, even under appropriate antibiotic coverage, we have to think of MIS-C. And on administering immunomodulators, if there is clinical improvement, it indirectly confirms the diagnosis of MIS-C. I would like to conclude saying MIS-C is a diagnosis of exclusion. High index of suspicion of MIS-C is important as these children become critically ill very soon. As many children are seropositive in this current epidemiology, clinician has to be careful to avoid overdiagnosis as well as underdiagnosis. As far as MIS-C is concerned, high index of suspicion is needed. With early diagnosis and initiation of treatment could be a lifesaver. It prevents hyperinflammatory state, multi-organ dysfunction, fatal complications following, duration of hospital stay for the patients and expenditure, use of inappropriate and higher antibiotics, which in turn leads to resistance. Steroids or any immunomodulators in the right time and at right scenario, it could be a lifesaver. Thank you.
Good study. Just want to ask you, did you say that no coronary involvement?
Yes, sir.
How many patients you had?
Sir, our study had 45 cases.
Who did the echocardiography?
Yes, sir. Pediatric cardiologist did it. We have.
We did.
Thank you.
Was cost the only factor for not using IVIG or availability?
Sir?
Was cost the only factor for not using IVIG or availability? Why did we not use IVIG in a lot of these patients? You had used IVIG in only.
Sir, high cost and availability was a serious concern. We had methylprednisolone as a first-line treatment. We gave IV immunoglobulin for cases, but that was not responding to IV methylprednisolone alone only, sir.
What is the dose of methylprednisolone used?
Methylprednisolone 1 to 2 mg per kg in a single dose. Up to 10 mg we gave. If there is no response, we started on IV immunoglobulins.
I now invite the last presenter for today, Dr. Arulalan. The topic for today's this thing is underserved urban and rural communities, affordable, scalable, replicable solutions with locally available resources. Vellore and Vallimalai experience.
Good morning, judges and dear friends. Professor TR was my MD examiner in 1990. Of course, thanks to Dr. Suresh, I didn't take written permission for this photograph. I took only oral permission. Next time I'll correct myself. See that child, look at the contractions in that child. I don't want to blame anybody. Our goal, this child should become at least rehabilitated to the maximum possible extent, what we can do. I always thank my teachers first. Without them, I'm not today as I am. Yesterday, I had presented on automation tools and intersectoral correlation using manual methods. Today, we'll be discussing on digital methods. Sadhu Balananda is 85 years old. Medical care is different, healthcare is different. Medicine, doctors, health, everybody, many people. How to innovatively disrupt them? What does that mean? Last week in IMA conference at Coimbatore, paper on PROS by Dr. Neminathan, myself, guided by Professor Nedunjalian, got the first prize, and we have asked to form an IMA research group for Tamil Nadu. But my objective is not that. See, BSS is conducting courses. My objective is beyond that. BSS is conducting courses. Why not IAP? See, at 60 years, I'm really feeling awkward to come and present with youngsters. But IAP should do something. See, we all our talents should go to the next generation. That we must have a pathway. All products and services in the initial stages are very complex. So only the expert can service it. Only the rich can afford it. Computers in 1960. But technology democratizes the situation so that it has become simple, so that anybody can service it and becomes less costly. Anybody can buy it, cell phones. Healthcare is no different. My 36 years of expertise can be innovatively disrupted. That can be embedded into a person with lesser training. It is possible. NICU, USA, a sensor-based oxygen delivery system was supplied, designed to supply between 0 to 7 liters. The resident kept it at 4.5 liters. The neonate received 0 liters. Why? Because that machine was not programmed to understand decimals. The moral of the story, from day one, we should get involved in developments of softwares. The CEO, Mr. Vijay, is sitting here. He has already spent 10 crores on this project. Money is not the primary motive. Few things can be done only on passion. This is one such thing. It was very, very difficult to translate this into software. It took literally months. We had to put in an Excel sheet. So many things had to be done. In the initial years, nobody admitted these children in schools. At that time, we supported them medically with so many things. Now she was forced to start her own school. Now that school is successful. Now everybody are admitting in that school. But unfortunately, the hospital has been closed because the norms fixed by the government, she could not cope up. So year 2000, Neurodevelopment Conference, CMC, Professor Prabhakar Moses was involved with the medical care, presenting a paper. After 15 years, these children are discharged. Boys, they were doing some STD booth work or furniture work. None of the girls survived. A shocked Dr. Nandini Mundkar asked, what happened? Dr. Prabhakar Moses did not say anything. And Dr. N.C. Matthew said, if you don't want, you need not answer. But we all know what would have happened to those girls. Is this acceptable? What can be done? First time in the world, pulse polio was done in Vellore. First time in India, measles program was conducted in Vellore, both by legend Jacob John. This was inspired by him. He used to say, we in private sector can do only a pilot study and prove that it is possible. It is up to the government to take it up. Twice a week, we went to the hills. We are doing camps on Sundays. But unfortunately, COVID broke out that. We are unable to follow this. This is an amazing story. Tomorrow, we are having the Christmas celebration at the orphanage. So a pediatrician need not restrict himself to pediatrics. The need is there everywhere. So in the initial years, using our MD, general internal medicine people, we could supply drugs, we could do dust, we could save 5 lakhs every year for this orphanage. Of course, out of that gratitude, they still follow. And everybody is eating that every day to Narkat and Ranipet, a van goes and distributes packets to the destitutes. See, these are the people we need our IAP support. That is Chairman Lakshmanan, his son is Arkat MLA. Okay. And of course, NSS volunteers, NAC accreditation committee really welcome these things. And of course, definitely how to disrupt this model. And they have put a stall in this thing. You can go and see near the cafeteria. And first 20,000 cases were done in my center. Now 150,000 throughout India. And this justifies my title, locally available resources, scalable, affordable, and replicable. And my handwriting can be read by machines in my own voice. And the respiratory rate can be easily counted. See, that people are waiting with, they're asking for chances, and we have a need. Chance should marry need. I've got more than 100 references. What I've done is I have summarized, grouped them in 10 things. Of course, want of time, I'm not able to explain, but just remember the second one, economy of permanence. Yesterday I told about that. Okay, thank you.
Go to the judges.
Thank you, sir. No, sir, but this has to go as a course, sir. See, IAP should consider, see, this is a correct time to make all other things. See, BS is nothing, sir. They are conducting, see, pharmacy assistant and community volunteers. Just you need to pay a deposit of 34,000 to BSS. No, we can conduct the course. That's what we are planning to do. If not for anybody, our own clinic staffs, front desk, we are planning to do. Rajan, thank you, Rajan.
Thank you, sir. Any questions? Thank you, sir.
Thank you, sir. Thank you, sir.
We congratulate all the participants for the presentations. May I now request the Secretary of the IAP TNAC, Dr. Rajendran, to hand over the certificates to our respected judges.